Greetings. I'm Jeff Moore, and I'm here to present the findings of the AMSSM Task Force on Financial Models for Exercise Medicine. I have no disclosures. I want to thank the physicians who participated in this project, who were invited with the goal of canvassing across the USA as a cross-cutting effort of three specialty societies that promote the promotion of exercise as a medicine: AMSSM, the American College of Sports Medicine, and the American College of Lifestyle Medicine. We were asked three questions by AMSSM past president Chad Carlson. In brief, who is profitably doing exercise medicine in America today? What would increase the adoption of providing such services? And what is the role of physicians in payer-based initiatives to promote exercise? There were three main efforts. The members of the task force were asked to personally canvass their connections in healthcare, leveraging their extensive Rolodex as physician leaders. We also conducted a physician survey, the results of which prompted a second survey. In the canvassing effort, task force members were asked to find out how they and their colleagues provide exercise medicine services, including billing, coding, fees charged, and how payers look upon these services. Task force members were also asked to inquire with health plans, employers, and payers on how these stakeholders view and compensate physicians for providing exercise medicine services. In the survey, the task force sought to understand how AMSSM physicians approach exercise medicine. Are you doing exercise counseling and prescription? Are you motivated? How much time and how extensive are your efforts? Are you using exercise professionals as allies? We also wanted to know if AMSSM physicians feel adequately compensated for this work, if you have pressure to do more lucrative things, if you feel like you're being effective at promoting exercise, and how willing and able are you to hire staff to assist with these kinds of services. Now to our key findings. Almost all AMSSM physicians are motivated and provide some measure of service on being active. The only ones who don't serve in positions where they don't do this kind of work with patients. Universally, the E&M codes are the major means for billing for this work. The task force had been concerned about the adequacy of billing methods, but our findings are that the E&M codes are widely deemed as adequate for this purpose, both in primary care and for consulting specialists. There is, however, widespread opinion that the E&M codes undercompensate for this work. Only a small minority of AMSSM physicians do exercise testing, and few seem to have internal or external resources to whom they refer patients for more extensive exercise medicine services. Payers also view E&M codes as the main process for exercise medicine services, though payers have more of a disease management orientation as opposed to a prevention orientation. There is some optimism that the new 2021 rules and payment rates for E&M billing will improve compensation for exercise medicine services. This is especially true because the new rules allow for billing for the additional time it takes to provide these services and to document these services. There is widespread, and based on the intensity of the comments, a profound frustration among AMSSM members that within their institutions they have little authority to promote exercise or to employ staff who can aid in promoting physical activity. It's worth noting here that the vast majority, some 75 to 80% of our survey respondents, are employed physicians. This cohort broadly feels that their performance metrics don't reward this aspect of their job. Physicians don't feel like they know enough about exercise science, and they feel that their efforts to promote physical activity may have limited benefit, in part because there is no support structure for this work. As a result, a significant number of physicians don't feel particularly motivated to do exercise medicine. Lastly, we found it extremely uncommon for payers or employers to provide financial incentives to physicians in support of physical activity promotion. Many payers and some employers have programs to support exercise among beneficiaries, employees, and dependents, but almost none seem to collaborate with physicians in such programs. Conversely, physicians are not well aware of what exercise medicine benefits employers and payers will provide to their employees and beneficiaries. The main messages of our effort are: number one, America needs better business models that do a better job of rewarding physicians and patients for engaging on the topic of exercise and physical activity for maintaining health and well-being. Number two, physicians need better training in exercise medicine. And number three, clinical exercise professionals should be part of the team and part of the business models. Let's look at these in more detail. I suggest pausing the slideshow while you read these next few slides. Our first recommendation is that the E&M codes are a pretty good way to provide exercise medicine services. Payers like this method, and E&M codes are particularly apt for any circumstance where physical activity or exercise is medically indicated because of some chronic condition. The new billing rules for 2021 have increased the value of E&M visits and the ability to bill for all of the time one spends on the encounter, including charting. This means that E&M codes are probably the best way for physicians to bill for exercise medicine in any productivity-based system, whether fee-for-service or for RVU quotas. Again, pause the slideshow while you read. But physician use of E&M codes is not enough to have substantial impact on patient behavior. Physicians need a supporting cast to do the majority of work promoting exercise and physical activity. Employed physicians, especially, are often viewed by administrators in light of their ability to generate revenues, with some experts estimating that a PCP produces over $2 million a year. At 40-hour work week, that's $1,000 an hour in direct and downstream income. In such environments, having an allied health professional trained in clinical exercise is a logical and economical way to deliver exercise medicine services. Further, the task force feels that these professionals should have their own set of CPT codes, primarily for the purposes of quantitating exercise medicine services, and that these codes should be covered benefits when provided in a medical setting on behalf of a physician. Again, pause. Physicians need more education and training in exercise science, in the role of physical activity in health and well-being, and on the clinical indications and uses of exercise. This training should occur at all levels of medical education. Again, pause. The cost of physician time is extremely high. In part, that's because here in America, the medical office staff generally cannot bill for their work on behalf of a physician. Moreover, physicians are more valuable when doing procedures, diagnostics, and managing complex cases, things that allied health professionals can't do. So while the task force sees the physician's advice as being the highest moral imperative, physician time spent counseling on physical activity has a high opportunity cost in today's healthcare market. We need clearer, evidence-based policies that guide how much exercise medicine should be done by physicians and how much should be done by allied health professionals. Again, pause. The task force's efforts demonstrated that when it comes to physicians providing exercise medicine services, the docs are willing, but the business models are weak. AMSSM should invest in advocating for new business models that are able to make optimal use of the physician's moral imperative while taking advantage of exercise professionals who can do the bulk of effort in managing medically directed exercise and physical activity for health promotion. Pause one last time. AMSSM should be a leader in advocating for exercise and physical activity promotion through primary care physicians. AMSSM should thus serve as liaison between organized medicine, employers, and payers. Institutions that promote physical activity for health and well-being should include their employees and their beneficiaries, primary care physicians, in these efforts. In conclusion, I leave you with these take-home summaries of what I've just discussed. Thanks so much to those of you who participated in our surveys, and thanks very much again to the members of the task force.